Hello, everyone. My name is Karampreet Kaur. I am a fourth-year medical student from the Vanderbilt University School of Medicine. I am presenting on a multi-center cohort study of age-related timeliness of treatment in patients with STEMI. I'm presenting on behalf of my study team, the Emergency STEMI Care Consortium, with my fellow co-authors listed here. This consortium involves 10 academic hospitals across the country, and its work is facilitated through the Emergency Care Health Services Research Data Coordinating Center at Vanderbilt University, run by my mentor, Dr. Yiadom. Our study focused on the emergency care condition of ST segment elevation myocardial infarction, or STEMI. STEMI is a life-threatening condition that occurs from the abrupt occlusion of a coronary artery from an intraluminal clot, erosion, fissuring, or dissection. Over 250,000 annual AD STEMI presentations occur, and most patients are age 55 and up. However, the overall proportion of MI admissions attributable to young patients has steadily increased over the last decade. When it comes to STEMIs, time is healthy cardiac tissue. There is a 7.5% increase in mortality for every 30-minute delay in definitive therapy. This therapy includes either thrombolysis or percutaneous coronary intervention, also known as PCI. The mechanical means of restoring blood flow with PCI is called balloon angioplasty. And guidelines recommend a door-to-balloon time of 90 minutes or less to preserve as much myocardial tissue as possible and decrease morbidity and mortality. Here, we illustrate the ideal care timeline for a STEMI patient who walks into a PCI-capable hospital's emergency department. Studies have shown that patients should ideally receive an electrocardiogram within 10 minutes of walking through the ED door. We call this the door-to-ECG time. And then, upon diagnosis of STEMI, they should get to the cath lab within 90 minutes of ED arrival, also known as the door-to-balloon time. Prior studies have shown that these target times are not met for all STEMI patients, and given the increasing rate of STEMI in the younger population, we as a study team set out to examine whether we are meeting these goals for younger patients. Our study hypothesis is that patients with STEMI who are less than or equal to 50 years old experience longer door-to-balloon times than those older than 50 years old. Our study was a 3-year, multi-centered, retrospective cohort study. The study population included adult ED patients who presented emergently and had a final discharge diagnosis of STEMI and were also treated with percutaneous intervention. This study focused on the timeliness of delivering PCI for STEMI patients who arrived to the ED without a known diagnosis. Therefore, we excluded patients who underwent a diagnostic electrocardiogram prior to ED arrival or had a first ECG in the ED that was non-diagnostic. Our primary outcome was door-to-balloon time. Our secondary outcome was door-to-ECG time, and covariates included patient demographic information, including age, sex, and insurance status, and patient past medical history as reported to ED providers. For our analysis, we compared the median door-to-balloon time and door-to-ECG times between younger and older groups using a Kruskal-Wallis test. We also created box plots to compare median door-to-balloon time between age sub-cohorts. Additionally, we stratified the population into 5 age sub-cohorts to compare potential differences in median door-to-balloon time using Mood's median test. We also performed descriptive statistics comparing covariates of interest using a chi-square test. Anticipating that other patient characteristics may potentially confound the association between age and door-to-balloon time, we ran an exploratory regression analysis modeling age with a restricted cube spline model. This included 4 knots that generated 5 age intervals for our study population. Moving on to our results, this patient flow chart illustrates the inclusion and exclusions for our analysis. We started with 2,045 ED STEMI patients in the ESC database. After we excluded those who did not have emergent STEMI, had an ECG prior to ED arrival, or who ultimately didn't receive PCI for treatment, we had 599 patients remaining. There were 23 patients with missing data and 2 with extreme outliers for door-to-balloon time, leaving us with an outcome analysis population of 576 patients. Our primary finding was that there was no significant difference in door-to-balloon time between STEMI patients 50 years and younger compared to those older than 50. Median door-to-balloon time for younger patients was 76.5 minutes, and for older patients was 81 minutes. Our sensitivity analysis found no significant difference even when the cutoff between younger and older was 45 and 40 years old, respectively. You can see this visually with this graph, where younger patients are on the left and older are on the right. Even though there were more older patients, the distribution of door-to-balloon time is visually about the same. When we further stratified the population into 5 age sub-cohorts, we found a significant difference across groups reflecting prolonged door-to-balloon time among the very young, defined as less than or equal to 30 years old, compared to the very old, defined as over 80 years old. The median door-to-balloon time in patients 30 and younger was 106.5 minutes, and for patients over 80 was 95 minutes. 67%, or 4 out of the 6 very young patients, and 56%, or 25 out of the 45 of the very old, had door-to-balloon times over 90 minutes. We similarly found no significant difference in door-to-ECG time between patients 50 years or younger compared to those over 50. Once again, our sensitivity analysis found no significant difference when the cutoff between younger and older was 45 and 40 years old. When looking at patient demographics, a higher proportion of younger patients were non-white, but there was no difference in Hispanic ethnicity between both groups. Older STEMI patients had a higher prevalence of risk factors for cardiovascular disease, with a statistically significant difference in the proportion of those with hyperlipidemia and hypertension. Of note, we observed that the prevalence of STEMI risk factors, such as diabetes, hypertension, and hyperlipidemia, among young patients in our study population were higher than the general population of adults 50 years and younger in the United States. The younger cohort included a significantly greater percentage of current smokers, and prior studies have theorized that active inflammation associated with smoking may contribute to STEMI risk in younger patients. Our exploratory regression analysis found that after adjusting for the influence of smoking, race, and other covariates, there was still no association between age and door-to-balloon time overall, or within 5 age intervals that are listed here. So in conclusion, we found no statistically significant difference in door-to-balloon time or door-to-ECG time between patients less than or equal to 50 years old and those over 50. However, we did find that the majority of patients 30 years and younger and those over 80 years old experienced PCI intervention beyond the target of 90 minutes. Additionally, we found that non-white patients and patients who smoke are disproportionately represented within the younger STEMI population. Our study certainly is not without limitations. Because this was a retrospective study, we examined the prevalence of disease risk factors between our younger and older populations as the information was known to ED providers at the time of the patient's evaluation. As a result, patients may have unreported risk factors or undiagnosed disease that were not captured in the electronic medical record. Additionally, we did not include 63% of our registry patients who were either diagnosed with STEMI at another facility and subsequently referred to a PCI center, or were diagnosed by EMS en route to the PCI center ED. Furthermore, none of the 10 sites included in the study were STEMI referral centers. Excluding the referred and EMS-diagnosed ED STEMI subpopulations did permit a more generalizable interpretation of the emergency department care delivered to patients who were considered quote-unquote undifferentiated or didn't have a diagnosis of STEMI prior to walking through the ED doors. Overall, our study highlights that the higher prevalence of STEMI risk factors, such as smoking, hypertension, and diabetes, among young patients who experience STEMI compared to counterparts in the general population, indicated need for ED physicians to ask about these risk factors even with younger patients. Furthermore, given the increasing prevalence of young STEMI in the US, acute coronary syndrome should be considered in the differential diagnosis of younger patients with acute presentations. Our references are listed here. Thank you to everyone for your time and to SAEM for giving us the opportunity to present our work on this virtual platform.